Good afternoon, everyone. Thanks for joining us this afternoon for this exciting webinar event. I think we'll get started now. The Ontario Public Health Association's Breastfeeding Promotion Network, as well as the Reproductive Health Work Group, are very happy to be able to bring Dr. Sarah Buckley virtually from Australia to Ontario today. As a charitable organization since 1949, the Ontario Public Health Association has strived to provide leadership on issues affecting the public health, as well as to strengthen the impact of people who are active in the public and community health. Working with various stakeholders across the health sector, OPHA provides its members timely information and analysis on issues affecting community and public health, professional development opportunities, access to local, provincial, and multidisciplinary networks, and advocates on health public policy. We would really like you to consider joining our network by becoming an OPHA member today. My name is Catherine Lowe's, and I'm a public health nurse from Niagara Region Public Health. I also am from the BFI strategy for the Ontario team and Ontario Public Health Breastfeeding Promotion Network. I'll be reviewing some of the housekeeping items and then formally introducing Dr. Buckley. I'm also accompanied online by Diana Sterling, public health nurse from Middlesex, London. Diana is a member of the OPHA's Reproductive Health Working Group. Deanna will be joining you after Dr. Buckley finishes her presentation to moderate questions and wrap up the webinar. I do have a few housekeeping items to cover just before we begin. So first of all, I would just like you to note that you can download a copy of the slide deck from the materials pod located on the top left part of the screen. If you have any questions or comments, as you can see, there's a chat box, and we encourage you to write any of your questions and comments there, and we will address as many as possible following the presentation. If you have any reason to contact us or for any technical support, you can send chat to the OPHA host. Following the discussion, we'll review a unique discussion room that's been set up specifically for this webinar, and it will be open for a week following the presentation. You can go into this chat room at any time, and you can share comments and questions, and they will be answered by Dr. Buckley. And Deanna, at the end of the presentation, will show you what that room looks like. Please note that if you have colleagues that want to hear the webinar, that the seats fill up much faster than we anticipated. So we are recording the webinar now, and it will be available for viewing on OPHA's website in the future. So now for our main presentation. The Ontario Public Health Association has partnered with the Public Health Agency of Canada, the Provincial Council for Maternal and Child Health, the Association of Ontario Midwives, and the BFI Strategy for Ontario to present Dr. Sarah Buckley, a world-renowned New Zealand-trained GP family physician, an advocate for physiologic childbearing and public health, and she's a public health PhD candidate. During this webinar, Dr. Buckley will share information on her groundbreaking report, Hormonal Physiology of Childbearing, and highlight the effects of labor and the birth process on lifelong health and well-being. This informative webinar will focus on current scientific understandings of hormones of pregnancy, labor, birth, and early parenting, and also review the impacts of common maternity care interventions on breastfeeding and maternal child attachment. So I will now pass the webinar over to Dr. Buckley. Thank you, Dr. Buckley, for joining us.
Thank you. It's a great pleasure to be here. Work on the other side of the world. Isn't technology amazing to be able to do this? And it's good for the planet to not be flying everywhere too. So yeah, welcome to this webinar on the impact of labour and birth on lifelong health and well-being. Big thank you to Deanna, Catherine, and everyone involved in making this happen, and to Daniel for the technical support. My intentions of this is to present evidence-based information from the Hormonal Physiology of Childbearing report, and there's a link there in the chat box if you want to go and download it. It's a free download. And the implications for women, babies, and public health, to describe the potential impacts of common maternity care practices on hormonal physiology and the lifelong implications for women, baby, and public health. And I'm also intending to empower healthcare and public health professionals to support physiologic childbearing and to promote informed choices. So we've just introduced myself, so you know all this about me. There's my family up here in sunny Queensland. Queensland in Brisbane, and just noting our dog Marla there, you may hear Marla bark, and if you're very lucky, as it's actually 5 o'clock, 5:30 in the morning, you may even hear some kookaburras. Let's see what happens. Okay, so this is what I've been up to in the last 15 years. So I've been lecturing and writing about pregnancy, birth and parenting for more than 15 years, and I've written 2 versions of my book, Gentle Birth, Gentle Mothering. It seems to have disappeared from the screen. I've also done lectures around the world. I've been to Vancouver, but not the rest of Canada. And I have a website, sarahbuckley.com. I have a membership website, Gentle Natural Birth. And on my website, sarahbuckley.com, there's also an e-book called Ecstatic Birth, Nature's Hormonal Blueprint for Labour. It's actually the first thing I wrote about hormonal physiology back in 2002. And that's available as a download. It's quite a nice summary. It's intended for parents, so fairly kind of simple as well. So this is my report, Hormonal Physiology of Childbearing, published last year with Childbirth Connection and the National Partnership for Women and Families. So we'll be talking about this a lot. I'll be kind of orienting you to it. And it's my intention also that you download it and use it in your practice as well. So this is the agenda. We'll start off with an introduction, and I'll sort of guide you through the report, tell you some of the background. And then we'll talk about some evolutionary perspectives. Then we'll go through the hormonal physiology of these 4 hormonal systems that are the basis for the report: oxytocin, beta endorphins, epinephrine, norepinephrine, and prolactin. And then we'll summarize the benefits of hormonal physiology for breastfeeding, attachment, and maternal mental health. And then we're going to look at the impacts of some common maternity care practices, induction of labour, epidurals, and caesarean surgery. And we'll also look at public health implications. So we'll discuss epigenetics, life course health development, and the precautionary principle. And we'll finish with a summary and some suggestions. So this is the report, and as I said, that's the link, and it's down in your chat box. I'm really recommending that you download it. It's a free PDF download. We don't have an index, but you can use the PDF search function to search topics, and I'll tell you how to do that in a minute. So if you go to the website, this is what you'll find. So I'll recommend you download the full report at the top. And there's also some material for women. There's a booklet on the top right there, Pathway to a Healthy Birth, this one here. It's also translated into Spanish, which is really valuable. There's fact sheets for clinicians here, fact sheets for policymakers. And there's also this really useful infographic called Pathway to a Healthy Birth. And all these things are freely available. You can print them out and share them as well. So this is the chapters in the book. So we start off with an introduction, and I'll be talking about some of those overarching themes and scopes as we go through. Chapter 2 is a whole chapter on the physiologic onset of labour and scheduled birth. So it details all the things that happen in the lead up to labour, and we'll talk about that as well. And then the next 4 chapters go through these 4 hormone systems, and then we finish chapter 7 with conclusions and recommendations. So in each of these hormone chapters, the first part of the chapter looks at hormonal physiology. So what happens in the normal functioning, first of all, outside of reproduction, secondly in pregnancy, then labour and birth, then after birth. So for example, for oxytocin, it's chapter 3, so 3.1.1 is an introduction to oxytocin outside of reproduction, which is actually a really nice summary of the current state of understanding of oxytocin. Well, it was a year ago, and then etc. So you can it's very predictable, and you can find your way around. Then the second part of each chapter looks at the impact of these 7 common maternity care practices. So first of all, maternity care provider and birth environment. For example, because the epinephrine, norepinephrine, see it's chapter 5. And then 5.2.1 looks at the maternity care provider and birth environment and the impact of that on the epinephrine, norepinephrine, and related stress hormone systems. And I recommend that section. I'll talk about that a bit more. But that looks at the impact of stress on labour and birth, on the hormonal physiology of labour and birth. Then 2.2 is prostaglandins for cervical ripening and labour induction. We didn't find a lot of material about that in any of the hormone systems. 2.3 is synthetic oxytocin, which we'll be talking about here. That's a big section, particularly its impact on the oxytocin section. 2.4, opioid analgesics. 2.5, epidurals, which we'll talk about. Caesareans we'll talk about. And then there's a whole section on early separation of healthy mothers and newborns. That's I'm not going to address here, but it's all in the report, so really encouraging you to navigate your way around it and look through it. As we go through, you'll also notice that there are some, I mention HPOC here and refer to some chapters where the thing that I'm talking about is in that chapter. So we have some definitions of hormonal physiology of childbearing. So we call this reproduction-related biologic processes from pregnancy through the postpartum and newborn periods in relation to innate endogenous hormone systems. So that's really what we're talking about here. And you'll notice that we're talking about more than hormonal physiology of childbirth. We're beginning in pregnancy and going through to the postpartum and newborn periods. And we think that's important, and we'll be describing why that is in a minute. The definition of physiologic childbearing, and we say childbearing conforming to healthy biologic processes. Now, you may know that physiologic childbearing is kind of the new term for what we previously called natural childbirth or normal childbirth. And I think it's nice because it does highlight the biology behind it. Some people define, or in some reports you'll find it's defined very strictly. It's not epidurals, it's not this, it is this. We rather prefer to define it as a continuum. So obviously some women will be right down one end of the continuum, maybe with a pre-labor cesarean where there's not a lot of hormonal physiology involved, and someone will be right at the other end where there's maximum physiology, minimum intervention. But every woman is going to be somewhere on that continuum. So what we really want people to think from is, where is someone on this continuum, and how can we add more hormonal physiology and benefit outcomes for her and her baby? So we kind of talk about the gap. We say mind the gap. What is the gap between biological expectancies, between hormonal physiology as it's designed to unfold and what's actually happening for this mother and this baby? And sometimes those hormonal gaps are really important. I mean, sometimes cesareans can be life-saving. So it's not about not doing the interventions. It's really about recognizing that there's a hormonal gap here and how can we fill in that gap. So we'll be talking about those things as well when we come to talk about the interventions. So I just want to talk about why we did this report, why hormonal physiology of childbearing. So the first thing to say is that there's a limited understanding of hormonal physiology of childbearing for mother and baby. And when you read the report, you'll actually find there's more questions than answers in there. There's so many areas where we really don't know some of the basic information. And the benefits of endogenous systems are often not considered in decision-making. So that's, again, something we want to put onto the agenda. What is the implications of this decision, of this intervention for hormonal physiology for mother and baby? And then if the intervention is required, how can we fill in that gap? It's a very illuminating perspective, and it has a salutogenic focus, which basically means it's focusing on positive outcomes. Conventional paradigms of maternity care really focus on pathology, what can go wrong. This rather focuses on what can go right and how can we promote things to go right, how can we support hormonal physiology. As you are aware, there's continuing increases in the use of maternity care interventions in the US, which is where this report is based, and other countries, including Canada. There's high rates of consequential interventions, and you'll see as we go through that, some of these interventions are very consequential for hormonal physiology, and these things are applied to essentially healthy mothers and babies. So, we're talking about a large population that's exposed to possible gaps in hormonal physiology. As you'll see, it's a major departure from our evolutionary and hormonal blueprint, and there's little research on the impacts of interventions, and we'll talk about that as well. So there is a potential for unintentional negative impacts. And again, obviously there's no intention, and we want the best outcomes for mothers and babies, but we need to be aware of what is the impact on hormonal physiology so we can take that into account as an additional consideration for benefit and harm analysis. So we also, I won't talk about this a lot, but I'll mention some of the animal study findings, but they do suggest the possibility of long-term effects, and there's actually minimal research on longer-term outcomes for women and children. We'll talk about that again at the end. And, we know from epigenetics, we know from developmental origins of health and disease that things that happen around the time of birth and pregnancy, postpartum, can set epigenetic structures and can have long-term impacts. And we haven't really thought about that in relation to childbearing. So let's look at evolutionary perspectives, which I find really useful in this work. So this is a quote from the introduction, and we say the hormonal physiology of childbearing has evolved over millions of years for reproductive success, If we're talking about humans, it's probably 5 million years. If we take into account our mammalian roots, and a lot of this hormonal physiology is common amongst all mammals, that's around 63 million years. So it's a very long time that these systems have evolved. So in addition to maternal and infant survival at birth, such success has depended upon lactation and maternal-infant attachment, which have evolved to be intertwined and continuous with the biologic processes of parturition. I'll explain that a bit more by what I call the triangle of reproductive success. And if you think about, any other mammal or our forebears, millions of years ago living in the wild, obviously it's critical that mother and baby survive the birth for reproductive success. But equally critical is breastfeeding. If breastfeeding isn't successful, then the baby would not naturally have survived. Obviously now we have breastfeeding substitutes, but we're talking about our hormonal imprint. We're talking about our hardwiring. And attachment is actually equally important for reproductive success. For our mammalian cousins, it's obvious, but for humans as well, in the wild, if the mother hasn't been rewarded and motivated to give the dedicated care that every mammalian mother gives to her newborn babies, then those babies wouldn't naturally survive either. So that's why we say that the processes of attachment and lactation are intertwined, continuous with the processes of birth. When we start to talk about the hormones, that'll become obvious because the hormones of birth are the hormones of breastfeeding, which are the hormones of attachment. So it's a very efficient process. The same hormones fulfill all of these functions. And again, another corollary that is if we look at common maternity, what we do common in current maternity care practices is we focus on the outcome of the birth. That's pretty much all we look at. That's all we measure, perinatal mortality. And we don't really look at the outcomes and breastfeeding are kind of regarded as soft outcomes. But the problem is when we start to interfere and disrupt the hormonal physiology of birth, we actually disrupt the hormonal physiology of attachment and breastfeeding. So we'll be talking about that some more as well. So disruption of perinatal hormones may impact not only labour and birth, but also breastfeeding and the maternal adaptations that promote maternal-infant attachment. So that will become obvious as we go through as well. Okay, so let's have an introduction to our 4 hormonal systems. And as I said, these are the chapters 3, 4, 5, and 6 in the report. On the slides, you'll notice that I do refer to some of the material in the report to orient you, and you can also use the search box, as I said, to search anything that I mention here. And in some of the slides, I'm also mentioning the authors of that report, and again, if you want to know the full citation, go to the report and input that author's name. So these hormonal systems, oxytocin, you probably know it very well as the hormone of love and attachment. Beta endorphins are hormones of stress, also addictive hormones, also hormones of pleasure. We have adrenaline and noradrenaline, which we use the US terms epinephrine, norepinephrine, the fight or flight hormones, hormones of excitement. I do actually talk about cortisol in the report as well, and prolactin, the hormone of breastfeeding, the hormone of milk. So let's go through these one by one. As I mentioned here, oxytocin 1 in the hormonal physiology of childbearing. Chapter 3, so 3.1.1 is that introduction to physiologic oxytocin systems outside of reproduction. So oxytocin was discovered around about 100 years. Oxy meaning fast, tocin meaning birth. That's why it's called oxytocin. We make oxytocin in the limbic system, the middle layer of the brain. It's actually made in the hypothalamus, stored in the pituitary gland, the posterior pituitary, from where it's released into the body. But at the same time that it's released into the body, it's also released into local brain areas. And that means it can have both physical effects in the body and also psycho-emotional effects through this local brain release. And it has both of these effects during sexual activity and orgasm, during pregnancy, labour and birth, and during breastfeeding. So because of its role in these critical reproductive events, it was named the hormone of love by the pioneer. We know also that it's released during pleasant social interactions. It's a pro-social hormone, which is again a bit of a theme in hormonal physiology of childbearing as well. We release it during skin-to-skin and eye-to-eye contact. And it's also been called the cuddle hormone because we release it with ventral contact. The oxytocin system runs down the front of the body, which is why we hug front to front and why it feels so good, because we release oxytocin. It's a hormone of attachment and maternal behaviour in all animals. And one of the ways it has positive effects is it reduces activity in the amygdala, the fear centre in the brain. And when we're not fearful, we can be more trusting in the brain. And when we're not fearful, we can be more trusting and more sociable. It has major impacts on the autonomic nervous system. It activates PNS, the parasympathetic nervous system, which is calm and connection, relaxation and growth, heal and the healing system, and reduces activity in the sympathetic nervous system, which is the fight or flight system. So it does things like slow heart rate down, reduce blood pressure, has major positive effects right to autonomic nervous system. It also has intrinsic pain-relieving properties, which is kind of helpful in labour and birth, and it activates the reward and pleasure centres. So because of all of these effects, it's been called the hormone of calm and connection by the worldwide oxytocin guru, Kirsten Uvnas-Moberg, and those are 3 of her books. She's done hundreds of research papers on oxytocin. I'll be quoting some of the research of herself and her colleagues as we go through. So it has some other important properties. That's the oxytocin molecule there on the right. It has a short half-life, but those of you who are clinicians are aware of this. It's broken down by an enzyme called oxytocinase, which is made by the placenta, actually, in pregnancy, and it's made even more in labour and birth. It's broken down even more quickly in labour and birth, and I'll tell you why that is a bit later on. It also has minimal passage through the blood-brain barrier. The blood-brain barrier is a structure that filters out what comes into the brain. We want to protect the brain and control what goes into it. So it's made in the brain and can go into the body. It can't go from the body back into the brain in clinically significant amounts. And if you've labour synthetic oxytocin, exactly the same molecule, or administered it, you'll be aware of this. You know, even though it can cause the contractions of labour, it doesn't have those positive psycho-emotional effects. It doesn't act as a calming and connecting, and it doesn't give pain relief. Now, the other interesting oxytocin, and this again is from some of the research by Uvnas-Moberg and colleagues at Karolinska in Stockholm, is it can be transmitted pheromonally from one individual to another through the vomeronasal organ in the nose. And what this means is that with another individual who has, full activation of the oxytocin system and calm, euphoric, even ecstatic, as I call it, especially in that time after birth, that wonderful hour after birth, then everyone who's near that person can also get those positive feelings. And you may recognize this from that wonderful time after birth where everybody feels euphoric, everybody falls in love with everybody, the partner falls in love with the mother falls in love with the baby, and the midwife, and the baby falls with everybody, etc. That's the pheromonal effect of oxytocin, and it kind of keeps us there, it keeps us being birthed. So in reproduction, it causes involuntary muscle to contract, for example, in labour, and it causes the ejection reflex, the sperm ejection reflex with male orgasm, the pelvic muscle contraction with female orgasm, the fetus, the pelvic, which I'll talk about, and the milk ejection, the letdown reflex with breastfeeding. It's an oxytocin joke. Why did the chicken cluck when she laid an egg? And the answer is arginine vasotocin. It's an analogue of oxytocin, and they're present right through the animal kingdom. Even an earthworm laying an egg releases a form of oxytocin. And as oxytocin is a hormone of orgasm, you could say when your chicken clucks when she lays an egg, she's probably having a good time. Okay, so in labour, as you know, there's a pulsatile release from the pituitary causing the rhythmic contractions of labour. Now, if we measure oxytocin in labour, we actually don't find a very big increase until the pushing stage. And there's a few reasons for that. One is because it's released in pulses. There's a few reasons for that. One is because it's released in pulses. So if we measure it right now, it might be the trough of the pulse or the peak of the pulse. Secondly, because it's broken down so quickly, we have to take special measures, considerations to actually measure oxytocin. But it has been done, and there's a slide showing oxytocin measurement and also the pulse frequency. And you can see in the light pink at the bottom that there's a small, a moderate moderate increase in oxytocin being released over 30 minutes, but a large increase in the pulse frequency. Obviously, more pulses means more frequent contractions. Now, I'm going to mention something that I call the snowball of labour, because labour is not a homeostatic process. You may have noticed that. Things don't stay the same in labour. Labour is an accelerating process, and I call it the snowball of labour. It starts small and gets bigger, and in the end becomes virtually unstoppable. And one of the reasons for this is because the physiology of labour involves a lot of positive feedback cycles. So this is one of the positive feedback cycles that involve oxytocin, and you may recognise this because it's actually analogous to the Ferguson reflex. And this has been shown in animals, and almost certainly happens in women as well. We have the same effects. So what we have here, just get my arrow here, that first of all, the contractions of labour become stronger, which gives stronger sensations, and that activates a specific neurological feedback system to the brain, and that causes more oxytocin release within the brain. And more oxytocin release in the brain causes more oxytocin release in the body, more oxytocin to the uterus, causing stronger contractions. So you can see how this positive feedback loop is going to increase oxytocin release during labour. Now, obviously, for this to happen, the oxytocin system has to be activated. And the way that the oxytocin system is maximized is by having sufficient oxytocin receptors to initiate this positive feedback cycle. Just talk about receptors. So just going back to the very basic physiology, I'm sure you know that a hormone is a substance that's made in one part of the body and has effects in another part of the body. And the way that it has effects is it binds to specific receptors. So for oxytocin, it has one oxytocin receptor. The oxytocin is released from the pituitary gland, travels to the uterus, finds the oxytocin receptors on the outside of the uterine muscle cells. It binds to those specific receptors like putting a key into a lock, and that turns the lock and sends a chemical message into the cell saying contract. Now, just as oxytocin or hormone levels can go up and down, receptor numbers can go up and down as well. And obviously, the more receptors there are, that's going to give more hormone sensitivity and more effects. So it's not surprising the number of oxytocin receptors increases, this is in the uterus, increases in the lead up to labour. So starting from non-pregnant, this is measured in real live women. We have 1 through to early pregnancy 11, through to late pregnancy 1100, through to early labour 3,500. So I can see that massive increase in uterine sensitivity to oxytocin at the physiologic onset of labour. We call this pre-labour physiologic preparations, and this is just one example, but there's many pre-labour physiologic preparations, and that's in Chapter 2 of the report where we talk about the physiologic onset of labour. And these are occurring over hours and days and weeks and even months towards the physiologic onset of labour, because it's so critical that the mother is fully prepared, is at maximum sensitivity for an effective and efficiency labour and birth. It's obviously critical that her baby is ready for life outside the womb, and then there's these hormonal messages that get passed between mother and baby to ensure that both are at this peak of readiness. And from Mother Nature's perspective, the bigger the event, the more preparation is needed, and the birth of the baby is even more consequential than a royal wedding. So, sometimes I say that, scheduled birth, an induction or a pre-labour caesarean is a bit like William and Kate turning up at Westminster Cathedral the day or the week before the wedding and expecting things to be the same. There'll be a whole lot of pre-labour preparations that are missing in this process. And again, I'll refer you to Chapter 2. We'll talk a little bit about that. So we have the pushing stage for oxytocin. The baby moves lower, pressing on these specialized nerves, sending that special signal to the mother's brain, causing oxytocin release, causing stronger contractions. So this positive feedback loop that happens at the pushing stage is called the Ferguson reflex. So what that happens is at that moment, what that means is at that moment of birth, the mother has these peak levels of oxytocin, but they're elevated even more in over the 60 minutes after birth, and I'll show you that on a graph in a minute. And it's related to the newborn breast massage and breastfeeding. Those behaviours actually feed into the mother's oxytocin increases. And at this time, it's really critical because it contracts the uterus to stop bleeding. Sometimes I say that, the mother spent 9 months becoming fully pregnant, and within a few minutes, she's not pregnant anymore. And particularly important is to seal off those blood vessels as her placenta peels off the wall of her uterus, and oxytocin is critical for that. It also has a really powerful effect of vasodilating her chest wall to warm her newborn baby. And this oxytocin flush can sometimes happen to women with sexual arousal too. It's a vasodilation that goes up even to the neck. But its physiologic function is to keep her newborn baby warm after birth. And as I'm sure you know, it's more effective than no matter how many layers you put around the baby or put it under a radiant warmer. The mother's body heat is more effective. And one of the reasons for that actually is because the mother's body heat is actually pulsed to the baby. Again, see section 3.1.4 of the report if you want to know more about that. I've just had this slight glitch, sorry. I don't know if you can see that. It's just coming back online. So I'm going to show you a graph in a minute that has the, it's based on some research that was done where they measured the mother's oxytocin levels every 15 minutes. And then they also videotaped the interactions between the mother and the baby. And then they put these two things together in this graph here, looking, and so you can see in the pink the mother's oxytocin levels measured every 15 minutes. Thank you to the mothers who did this research. And all the other colours are actually the baby's behaviour. So I'll just get the pointer. So here we have the mother's oxytocin levels in the pink. So we have initially in the first 15 minutes the mother's oxytocin levels go down, and then they rise somewhat. And they rise in parallel with this thing here, which is the baby's breast massage. So the first thing the baby's doing at 15 minutes is beginning to massage the mother's breast, has a peak of breast massage at 30 minutes, coming down in the first hour. And at 60 minutes, the baby's doing less breast massage and more of the yellow, which is sucking the fingers or sucking the fist. You probably have seen that. The baby sucks the fist, gets the salivary juices going, etc. So that peak of finger sucking at 60 minutes, and then in the second hour, this is the results of one mother and baby. So second hour, this baby began even more breast massage, and then at 90 minutes in the yellow, the baby got on and began suckling. So what happened, what we see is the interactions between, so in the green the baby begins suckling. We see the interactions between the mother and the baby. So as the baby begins this first burst of breast massage, the mother has a peak of oxytocin in parallel, and you can see those things look very parallel, and statistically they're highly correlated. As the baby begins finger sucking, obviously not stimulating the mother's breast, there's a trough in her oxytocin here. The baby has another burst of breast massage. The mother has a second peak of oxytocin. As the baby gets on the breast, the mother has a third peak of oxytocin. So you can see just visually the correlation between the baby's breast massage behavior, the baby's suckling behavior, and the mother's oxytocin response. Now, what's even more interesting to me about these results is if you look at the mother's oxytocin result here, peak, now you'll see this as a logarithmic scale. So between 1 and 2 is actually a factor of 10. So in this first 45 minutes, the mother has increased her oxytocin levels by 10 in response to the baby's breast massage. The second oxytocin peak is lower, even though the baby's massaging even harder. And the third oxytocin peak is the lowest, even though the baby is actually suckling the breast, which you would imagine would be the most stimulation. So what this means to me is that the mother's oxytocin sensitivity is declining over the first hour to hour and a half. And it really highlights the wisdom of what we know about the first hour, how sensitive it is, and really the whole baby-friendly hospital initiative that focuses on interactions between mother and baby in the first hour. So it's a beautiful illustration of that. Okay, so the baby also releases oxytocin in labour. The baby has high levels at birth, again peaking in that first hour and being present in breast milk. There's a lot of areas of oxytocin research at the moment. It's kind of flavour of the month. If you were to search oxytocin in PubMed, you'll find hundreds of thousands of hits. It's really being researched in almost any kind of physiological and physical and psychological and psychiatric condition as well. So we know it's involved in bone health, osteoblast function and osteoporosis. It's a hormone of satiety, so it's involved in food intake and obesity, inhibits the growth of some cancers, protects from heart disease. The heart is highly innervated or highly has a lot of oxytocin receptors, And it also has been, as I said, involved in or being trialled in many, many psychological and psychiatric conditions, including depression, anxiety, obsessive-compulsive disorder, autism, post-traumatic stress disorder, and sexual function. It's also thought to mediate the effects of Prozac and the other SSRI drugs. So some people say we all should have Prozac in our water because we're all a bit depressed, but probably we just need more of oxytocin, the cuddle hormone, so we need more cuddles. Okay, so let's look at beta endorphins, and I'm sure you know these as these natural opiates. They have properties in common with morphine, heroin, pethidine, meperidine, and fentanyl. We release them when we're under stress and duress, and they act as natural painkillers, so very useful in labour and birth. They're also substances of pleasure, euphoria, and dependency, and the reason for this is they so powerfully activate the reward and pleasure centres in the brain, and this happens during critical reproductive events, and I say it's a bit like Mother Nature patting us on the back, saying you've done a good job, do more of it, make more babies, have more babies, breastfeed more. And like oxytocin, they're also pro-social hormones. As I said, that's a theme here as well. So in labour, they're powerful analgesics. For some women, they do totally abolish the pain of labour. For most of us, we still have some of that experience. But what I say is they put us into this altered state of consciousness where we can transcend the stress and pain of labour. And also at the same time activating those powerful reward and pleasure centres in the brain. So we call them hormone pleasure and transcendence. So in labour, levels gradually increase, and you'll see this in a minute. Becomes equivalent to endurance athletic performance. You could say it's the best runner's high we'll ever get. And so this is what it looks like as measured in the bloodstream. And just remembering that the place that beta endorphins are working is actually inside the brain, and we can't measure that in women. But from non-pregnancy through to early labour, and you can see those peak levels in advanced labour. And in this graph, as measured in the bloodstream, they come down quite rapidly by 30 minutes postpartum. But we know that the half-life in the bloodstream of beta endorphins is 37 minutes. But we know from human studies that they have a much longer effect in the brain. And this was actually done on a man with intractable cancer pain who had a shunt into his ventricles. And they administered one dose of beta endorphins, and he had pain relief for 21 hours. So very prolonged effects within the brain. And so if we were to measure the brain, it's probably going to be up here for a prolonged period of time after labour and birth. The baby also secretes beta endorphins in labour. And again, it's helping the baby to deal with the stress and pain of labour. It's protecting the fetal brain from very low oxygen levels, according to animal studies. Levels peak at birth, subsiding over the first 2 hours for the baby, and it's also present in breast milk. I always think when the baby falls off the breast drunk with breast milk, that's beta endorphins. So released for mother and baby with breastfeeding, also with contact between mother and baby, imprinting the pleasure and reward centers. So what I say about beta endorphins and oxytocin is they're activating the pleasure and reward centers during labour and birth, and then maximally after birth. So the mother feels rewarded for her major reproductive event, but also not just activating, but also imprinting the reward and pleasure centers, so that as she meets her baby for the first time, she's imprinted, oh, here's my baby, but my baby's a source of reward and pleasure for me. So it's positively addicting the mother and the baby, and it's a good feeling because it activates the reward and pleasure centers, but really the intention of this is to reward and motivate the mother to do all those behaviors, and not just human mothers, but every other mammalian mother, because of course dogs and cats and elephants, they don't go to prenatal classes to learn how to take care of their baby. They do it because it feels good. Yeah. Okay, so that's the beta endorphin system. So let's look at the catecholamines. So these are adrenaline, noradrenaline, epinephrine, norepinephrine, the fight or flight hormones released when we're anxious, frightened, hungry, cold, and also excited. I hear that Canada is a nation of extreme sports, so many of you are probably familiar with the adrenaline rush from extreme sports. So I'm calling them hormones of excitement. So what happens, and I'll show you a graph of this in a minute, so levels gradually increase as labour progresses. However, very high levels have a different effect, and I call this the saber-toothed tiger effect, because it's a survival strategy for any mammal, including our forebears giving birth in the wild. So if a labouring female encounters a saber-toothed tiger in labour, she'll have a big surge of adrenaline and noradrenaline, and these very high levels will reduce her uterine contraction, so they'll give her the break that she needs from labour. They'll also shift her blood supply to the parts of her body she needs for fight or flight, her muscles, her major muscle groups, her heart, her lungs. But in doing so, will shift blood away from a uterus and baby. You know, it's a basic survival strategy. At that point, with the saber-toothed tiger in your face, your uterus is not an essential organ. So the idea is that then she'll take effective action, run away, find a safe place, adrenaline levels will go down, and blood supply to her baby can come back. Now, the Liedermans and colleagues did some detailed research in the 1980s measuring women's adrenaline levels in early labour, and they found that the higher the level was, the more likely that woman was to have a prolonged labour and to have adverse fetal heart rate patterns, which really illustrates this prolonged labour from reduced uterine contractions, and the baby may have some effects from the reduction in blood and oxygen. So labour stress can elevate catecholamine levels, including when the labouring female does not feel private, safe and unobserved. So these are, in my longer lectures, I talk a lot about the need for the labouring female to feel private, safe and unobserved. And if you think about, our origins, the way we're hardwired for successful birth and the why, obviously it's critical that the labouring female is aware of danger. And, labouring women as well as labouring female mammals, can have these supersonic senses, can be very aware of what's going on around them, even though they're in this kind of altered state of consciousness from the endorphins. And obviously that's been critical through millions of years of evolution. It's part of our hard wiring to know in labour, are we actually private, safe and unobserved? Is this a safe place to give birth? Because of the extreme vulnerability of the labouring female. You can't enact fight or flight very easily in labour. So there's the strange smell, the strange noises, the amniotic fluid, the blood, the placenta, the baby, is very vulnerable to predators. So it's critical that the labouring females have this sensitivity to danger, and that they, really have these super sensitivity to whether they're private, safe and unobserved. And again, I'm going to refer you to 5.2.1 in the Hormonal Physiology of Childbearing, which has a lot of detail about stress in labour, what systems it activates, and what we know from studies of animal stress in labour. So that's what happens in physiology, but there's also this gradual rise in catecholamines as labour progresses, and this natural rise at transition. I'll show you that on the next slide. And the woman may experience what's been called physiological fear. Oh my God, I can't do it, cut it out of me, take me home, take me to hospital. That's kind of transition as we call it. And the woman's in a transition from one hormonal state to another. Now, at this stage, very high levels of catecholamines can paradoxically promote contractions. I'll explain what I mean by that. Basically, if the saber-toothed tiger turns up at the end of labour, when labour is this unstoppable snowball, it makes much more sense for the mother to give birth quickly and easily, scoop up her baby and run away, rather than to try and stop labour when it's virtually unstoppable. And that's called the fetus ejection reflex. So this is what it looks like. And you can see the mother's adrenaline levels here peaking, and this is actually as measured in her urine and compared to her own levels at the same time of day in late pregnancy. So she's at 850%, 8.5 times her own natural adrenaline levels at the same time of day in late pregnancy. So a huge surge in adrenaline. And as I said, the sense I make of that is it's there to make sure that the mother's senses are alert. So she's alert to any presence of danger. And noradrenaline does get elevated, but not to the same extent. So the baby also has a catecholamine surge in labour. Catecholamines benefit the baby as well. So it has a neuroprotective effect in the brain, reducing the cell death from hypoxia. I'm not going to emphasise that a lot, but as you go through hormonal physiology, there's many features that protect the baby's brain in labour. Oxytocin system actually has a neuroprotective effect as well. It also stimulates anaerobic glycolysis, which is the metabolism of glucose at low oxygen levels, which is going to be inevitably happening in labour. So that makes sure the brain and the heart can use glucose at these low oxygen levels. So at the time when the baby's contraction, when the mother's contractions are the longest, strongest, and closest together in late labour, these neuroprotective features are fully active because the baby's catecholamine surge is activated. And it's activated through hypoxia in late labour, but it's also activated through pressure on the baby's head. So as the baby gets low in the pelvis in late labour, it activates a catecholamine surge. So the catecholamine surge not only protects the baby at that time, but it's also preparing the baby for life outside the womb, because obviously by the time the baby's there in late labour and the contractions are close together and the baby's head's being squeezed, the baby's going to be born any minute. So it improves breathing, which is obviously the most critical transition the baby has to make, increases lung surfactant, which is a lung lubricant, increases lung liquid absorption. The lungs are full of liquid in the womb, improves lung compliance or elasticity, and dilates up the airways. Protects the baby's heart and brain, increases blood flow to the vital organs, mobilizes fuel because the baby any minute is going to be detached from placental nutrition. The baby's going to have to make their own metabolic fuels until the mother's milk comes in, breaks down normal fat into fatty acids, breaks down glycogen into glycose, and importantly stimulates new production of glucose by the liver. Dilates up the pupils, increases alertness. Babies born with a good catecholamine surge are those babies that are wide-eyed and alert. I'm sure that you know that or you've seen pictures. Facilitates bonding and also initiates thermoregulation. It begins the process of burning brown fat because the baby is also going to have to make their own heat once they've been born. So all of these ways that it helps the baby to adapt to life outside the womb. And we'll come back to this slide because these are also all the adaptations that the caesarean babies, and particularly pre-labour caesarean babies, can miss, and really kind of predicts the morbidities of caesarean-born babies. As we say, the bigger the event, the more preparation is needed, and this is true for the baby's catecholamine systems. So what happens before labour is in all of these areas, the baby's catecholamine receptors are upregulated as well to make sure that the baby will be fully and effectively responsive to the catecholamine surge in labour. So the baby's wide-eyed and alert at birth. What happens then, the baby's born with these high levels of adrenaline and noradrenaline, but they drop rapidly with skin-to-skin contact because that switches on oxytocin and switches on breastfeeding behaviours as well. The peak that the baby gets of noradrenaline also enhances olfactory learning. The baby learns the mother's smell by the noradrenaline peak at birth, which lasts a short time for the baby. So that's the catecholamine system again. That's chapter 5 in the report if you want to know all about it. And prolactin, our last hormonal system that we're talking about here, is prolactation, the major hormone of breast milk synthesis, as I'm sure you're aware, but it's also a critical hormone in maternal attachment in all, not just mammals, but actually in other species as well. It's involved in caretaking, taking care of anyone's baby, increases your prolactin, and it's a hormone of fathering as well as mothering. It's a hormone of paternity. So in any species where the father is involved with care of the young, including penguins, they produce prolactin. You may have seen pictures of penguins, the father spending those long blizzardy winters with the egg balanced on their feet. That's prolactin. And then they produce crop milk before the mother comes back. That's prolactin as well. So I call it the hormone of breastfeeding and tender mothering. I could actually call it the hormone of tender fathering as well. So in women, we have a steep rise at the end of pregnancy, and we know that in animals there's a peak on the day before the physiologic onset of labour, and we know that elevations in prolactin increase the number of receptors in the brain and also the mammary glands. We haven't had any women put up their hands to have their mammary glands and brain sampled in the lead up to labour for prolactin receptors, but I think we can presume because we have the same requirement for successful breastfeeding that this is going to happen as well. And we know that with the prolactin system, if you are a lactation consultant or involved with breastfeeding, you probably know the prolactin receptor theory, which states that when we get these high prolonged levels of a prolactin elevation, it increases prolactin receptor formation. So again, the bigger the event, the more preparation is needed. So all these increases in prolactin receptors in the mammary glands and the brain to activate breastfeeding, lactation, to activate maternal behaviours immediately after birth. So what happens for women in labour, and I'll show you on the next slide the actual graph, is that levels actually drop and then rise again steeply at the end of labour. Now, one of the things that increases prolactin is pulsatile oxytocin release. So those pulses of oxytocin that are happening in labour, and especially those large pulses at the end of labour, we think that's what causes this big surge at the end of labour. And beta endorphins also increase prolactin release, so at the same time the mother's having these sensations, the labour pains, it's increasing her beta endorphins, which is increasing her prolactin as well. So there's complex interactions between all of these hormones that we don't fully understand, but again, I'll refer you back to the report for more discussion about that. So you can see on the slide, it's peaking. You can see that there's this elevation before labour and birth, the decrease during labour and birth, that in the hour before the actual birth, there's a steep increase, and levels are elevated peaking at 1 to 2 hours and elevated up to 6 hours afterwards. And as I said, we think that postpartum elevation is there to ensure the production of prolactin receptors for a long-term successful breastfeeding. So prolactin, as I said, is a hormone of caretaking. It's a stress-reducing hormone, again, something that we want for lactating mamas to have low stress levels. It's secreted into breast milk, and we think it may be one of the factors that helps the breastfed baby's brain development. Okay, so that's kind of hormonal physiology, very basic information. Again, I'll refer you back to the report for all the details. But I want to review some of the benefits of physiologic birth for breastfeeding, attachment, and maternal well-being. So I hope that you've picked up the triangle of reproductive success and how all of these hormones are involved not just in birth, but also in attachment and breastfeeding. So the breastfeeding hormones, oxytocin, letdown reflex, endorphins, reward breastfeeding, prolactin makes breast milk, but also here adrenaline and noradrenaline. Remember those peaks at the end of labour and birth for mother and baby that make sure that both are wide-eyed and alert for the initiation of breastfeeding. Attachment hormones, all of these are attachment hormones, oxytocin, endorphins, prolactin. Noradrenaline is actually an attachment hormone. We know that from animals, and not just generally, but specifically in labour. It has to be released in labour to switch on attachment for mother and baby. And stress-reducing hormones, remember oxytocin, endorphins, and prolactin are also stress-reducing hormones. Rewarding hormones, remember oxytocin and endorphins both stimulate the reward and pleasure centers. So we have, oxytocin hormones that are promoting breastfeeding, promoting attachment, reducing stress, and rewarding the mother and baby. So the way that physiologic birth optimizes oxytocin, which makes sure the mother's calm and connected. Remember those levels peak at birth and in the first hour after birth. I think I've got the graph here in the next slide. Producing an ideal hormonal situation to initiate breastfeeding. And remember that maximum sensitivity, those bigger peaks of oxytocin in the first hour. That pulsatile oxytocin is promoting prolactin release. It's stimulating the attachment centers, switching on what are sometimes called the maternal circuits in the brain and activating those pleasure and reward systems. So see that big peak of oxytocin in that first hour after birth, 10 times what she had at birth even. Endorphins are also optimizing all of these processes by switching on pleasure, reward, and attachment. And remember from that graph that the brain levels are likely elevated for many hours after birth, that longer half-life in the brain, imprinting pleasure and reward with breastfeeding and infant contact and care. So this is a kind of a group of physiological processes that I've called biologic bonding after Niels Bergman, who writes about that in his breastfeeding book, Suckling Skills. And beta endorphins, so this is what it looks like. Remember the high levels in advanced labour and then probably those levels even higher and for a prolonged period in the brain. So biological bonding happens when these peaks of oxytocin and beta endorphins stimulate these brain reward centres. That's imprinting reward in relation to infant contact and care. In animal studies, as we said, noradrenaline is essential intrapartum, prolactin is also involved, and these peaks of central brain-based oxytocin and prolactin receptors even before the physiologic onset of labour. So what that means, some of the implications of this is if the mother doesn't have a physiologic onset of labour, what's happening to her central receptors for attachment, for breast pleasure? We don't know the answer to that question, but probably they're going to be reduced. There's probably going to be a central hormonal system gap there as well. The bigger the event, the more preparation is needed. I'm sure you've got that message. So biological bonding, certainly true in animals. It's why any mother mammal looks after her babies, because it feels good. And this was actually a rat study where they offered the mother rats in the early postpartum period a choice between contact with their babies and cocaine, and they all chose the babies. It's more rewarding than cocaine, which is apparently very powerfully addictive. In relation to human mothers, although, as I said, we can't measure the brain levels of hormones, we can actually measure what's going on in the brain with MRI. So there's been a lot more studies of MRIs in relation to mothering thoughts, mothering behaviours, and in summary, human neuroimaging studies demonstrate parallels between animal and human maternal caregiving responses in the brain. So basically we're using the same mammalian caregiving circuits. And this second study, this MRI, was done by Swain and colleagues, and they looked at mothers 2 to 4 weeks after giving birth who'd had a vaginal delivery, VD, or pre-labour caesarean. And they wheeled them into the MRI machine and played them the sound of their baby crying. And what they found was that the vaginal delivery mothers had greater activation in the sensory processing, empathy, arousal, motivation, and reward centres compared to mothers who'd had a pre-labour caesarean. So these mothers that had the pre-labour physiologic preparation, that had these hormonal peaks of labour and birth of oxytocin, endorphins, noradrenaline, prolactin, switching on these mothering behaviours, these reward centres that were still obvious and more activated 2 to 4 weeks after birth. Now, obviously, I'm not saying that mothers who have a pre-labour caesarean can't enjoy their babies, etc., can't be fantastic mothers. Obviously, we can be fantastic mothers to babies that we adopt. But Mother Nature intends that we have this head start, switching on our reward and pleasure centres so that we'll find our babies ongoingly rewarded. So that if mothers miss the switching on of the pleasure and reward centres, there's a hormonal gap there. So we'll talk a bit more when we come to caesarean about what we can do about that hormonal gap. So we have the epinephrine, norepinephrine, adrenaline, noradrenaline systems also optimized by physiologic birth, which means that mother and baby are alert and energetic in that first hour after birth, ideal for breastfeeding, and that noradrenaline in labour for attachment, as we talked about. So catecholamine levels, remember that peak that the mother gets in late labour, so that she's really switched on as she meets the baby for the first time. Prolactin is also optimized. Remember the pre- and post-labour elevations, likely promoting receptor formation for long-term breastfeeding success, switching on breast milk production, switching on tender mothering, as I call it, maternal physiological and psychological adaptations to motherhood, stress fixing and attachment as well. So remembering the peaks before labour and those peaks after labour. And it may be that both of those are actually optimizing prolactin receptors in the breast and in the brain as well. So maternal mental health, so it is a really important topic. It's a very topical topic, we could say. I did look at that in relation to hormonal physiology, but there really isn't much published. There's not a lot of research on the relationship between the experience of birth and maternal mental health. But we know that these peaks of physiologic hormones, as we mentioned, are stress-reducing, reward and pleasure, imprinting the hormonal peaks and reinforced with each episode of breastfeeding and contact and care for the baby. And one might imagine that all these positive hormonal impacts on the brain would benefit maternal mental health. As I said, it's not well studied, but there was an interesting study from 2012 that randomized women to 2 hours of daily skin-to-skin contact with the baby in the first month, and they found reduced depression scores because skin-to-skin contact, as we mentioned, breastfeeding, skin-to-skin contact in particular, and episodes of care reinforce all of these hormones as well. So, I'd really like to see more research in this area. Well, that's kind of physiology, breastfeeding, how it all hangs together. So let's look at what happens when we bring in various interventions and how they impact the hormonal physiology for mother and baby. So the first thing to say is the risk versus benefits of all obstetric interventions need to be considered for each individual woman and her unique situation. From my perspective, the woman herself is best placed to decide, given all the time and information that she requires. This is informed choice. Mind the gap. So that's a really important part from our perspective of informed decision making, is realizing what the gap is and taking that into account in benefit risk analysis. So let's look at the use of synthetic oxytocin. So what I found from the internet is that the Ontario induction rate, this is from 2011, so maybe different now, was 30 to 35% in low-risk nulliparous women, 22% in low-risk multiparous women. Also found an interesting figure from Vancouver where an obstetrician there, Dr. Leduc, mentioned that the induction of labour represents 25 to 33% of our intrapartum workload. Very interesting to do a benefit cost analysis on that and see whether we're actually getting good value. So the first thing to say about synthetic oxytocin is it's chemically equivalent to natural oxytocin. It's exactly the same molecule, but it acts very differently, first of all, because it's not released in pulses. Remember how it's released in pulses from the brain, causing the rhythmic contractions of labour, and it's broken down quickly by oxytocinase, which ensures that the receptors in the mother's uterus in physiologic childbirth are exposed to endogenous natural oxytocin episodically. So you get a pulse and then it's broken down quickly, another pulse broken down quickly. So you get a more constant high-level exposure from synthetic oxytocin. There's also higher levels likely if the mother's been induced. She doesn't have that full, remember the 3,500 oxytocin receptor numbers, so she's going to need higher levels to stimulate her uterus, and also the minimal passage through the blood-brain barrier. So it causes contractions that are longer, stronger, and closer together than the woman would naturally have at that time of labour. So she can get hyperstimulation in early labour, and it reduces each of those contractions, reduces fetal blood and oxygen. And in early labour, the baby's head is high. It's not going to be down low. The baby's not going to have that full catecholamine surge stimulated. The baby's not going to have the full physiological neuroprotection. Yeah. So from a hormonal physiology perspective, that's actually why it requires monitoring. The baby doesn't have their own. There's a hormonal gap there in the baby's neuroprotection, and it does require monitoring. And also because the mother hasn't had the chance to build up her analgesic systems, analgesia is likely to be needed for her as well. Now we know, so that I mean the constant high-dose exposure of synthetic oxytocin, so that's unphysiologic, and constant high-dose exposure can have an effect on uterine oxytocin receptors. It can down-regulate or desensitize the uterine oxytocin receptor system, which basically means when the mother needs to respond to oxytocin after the birth to contract her uterus, she's not able to do that as effectively. So it does increase the risk of postpartum hemorrhage. We know that synthetic oxytocin in labour increases postpartum hemorrhage. And it can also initiate the cascade of interventions, cause more pain, the woman needs analgesia, and so on it goes. And really the hormonal physiology of childbearing is a really good way to understand the cascade of intervention. Now, I want to emphasize that it doesn't give negative feedback to endogenous oxytocin release as far as we know. We don't know for sure because we can't measure it in women's bloodstream. We can't differentiate between their own endogenous oxytocin and synthetic oxytocin. But as far as we know, the oxytocin system doesn't work in a negative feedback loop in labour. It more actually works in the positive feedback loop that we're talking about, which means that anything, including synthetic oxytocin, if it causes strong contractions, it's going to activate those positive feedback loop and initiate labour, which is kind of what we see clinically, right? If the woman's got enough responsiveness, enough receptors, then causing contractions to start by any means, by prostaglandins, by synthetic oxytocin, by Foley catheters, can actually initiate the full-blown labour. So what about its impact? So we know that it can impact labour and birth. What about impacts on breastfeeding? And really, what's most shocking, one of the big gaps here is really that there's very few studies. I mean, we know that oxytocin is a hormone of breastfeeding, but we haven't actually registered that using it in labour could impact breastfeeding. So there's very few studies, no high-quality randomised controlled trials. But we do have some findings from cohort studies and observational studies. So these 3 studies, one found less breastfeeding in the first 4 hours for synthetic oxytocin exposed mothers and babies, lower newborn suckling scores, and reduced pre-breastfeeding cues. The Spanish cohort study and a couple of other older studies also found more likelihood of formula feeding, and in this study, women who were exposed to synthetic oxytocin were more than twice as likely to stop breastfeeding under 3 months. And one of the reasons for this might be because it disrupts the mother's endogenous oxytocin system. So this study actually measured the amount of oxytocin the mother released during breastfeeding during the second day postpartum and compared women who had synthetic oxytocin and not had it. And basically, the more they'd received, the lower their own endogenous oxytocin levels were during breastfeeding. And how does that happen? We don't actually know because I just said it doesn't give negative feedback. So how does synthetic oxytocin administered in labour reduce the mother's own oxytocin after labour and birth? And we can't answer that question, but we know that there is an effect there. This more recent study just from this year found that 2 months after birth, women who received more oxytocin, and this was a dose-response effect, were less likely to be breastfeeding and more likely to be depressed or anxious on the scales and have higher oxytocin levels as well. And why do they have higher oxytocin levels? You'd think that would be a good thing, right? Well, we think probably that there's some interference with the receptor system, that their receptor system is less sensitive, so therefore they need higher oxytocin levels to try and make their oxytocin system work, but even then it's not working because it's not enough to counteract depression and anxiety. So that's a really interesting interesting finding. This study looked at the developmental testing at age 5 of synthetic oxytocin-exposed children, and they did find an increased risk of failing the gross and fine motor tests. This study published last year. There are animal studies also showing impacts from a single exposure to synthetic oxytocin within 24 hours of birth. So these Prairieville studies done by Sue Carter and colleagues found changes to adult sexual and parenting behaviours. One animal study in mice found, again, a single high-dose synthetic oxytocin within 24 hours of birth found changes in brain chemistry, dopamine and serotonin functions in adulthood. Given that these are the things that we know from animal studies, we know that it's a breastfeeding hormone, we know it has psycho-emotional effects, what could be the postpartum effects for women and children of perinatal exposure to synthetic oxytocin? Well, that is part of my PhD thesis. I'm doing a systematic review on that. And, you know, the most shocking thing to me is that we haven't really asked those questions in a systematic way. So I'm guessing that the answer to this question is probably going to be we don't know. Yeah. But let's see what happens. I'm hoping that we'll publish that next year. So let's look at so that's synthetic oxytocin, the impact of epidural. So a lot more exposure to epidural analgesia is happening more and more. In Ontario, your figures from 2014 show that 65% of women having a vaginal birth used epidurals. The Australian equivalent, looking at the percentage of women with labour onset, was 33. So we have lower levels here, but your levels are creeping up to what the US kind of levels are, which is in the 70s and maybe 80s as well. So very widespread use of epidural analgesia. As I'm sure you know, it's an injection of local anesthetic nowadays with an opiate drug, fentanyl or sufentanil, into this epidural space around the spinal cord, and it basically acts as a dental anesthetic. It stops the transmission of signals from nerves passing through that space, and the reason it works is because the local anesthetic is injected next to the nerve. Yeah, if we just took the local anesthetic, if you went to the dentist and he injected the local, or she injected the local anesthetic into your bloodstream, it obviously wouldn't numb your mouth. And similarly with an epidural, it works because it's injected right next to those nerves. But the epidural drugs do enter the bloodstream fairly quickly. Within 15 to 20 minutes, they cross the placenta and they enter the baby's body as well. That's absolutely for sure because you can measure it in the baby's cord blood, all of these drugs. The World Health Organization says that epidural analgesia is one of the most striking examples of a medicalization of normal birth, transforming a physiological event into a medical procedure. And one of the reasons that it does this is because it interferes with these with hormonal physiology in a major way during labour and postnatally. So in relation to oxytocin, if you remember our positive feedback loop, if where the positive sensations lead to increased oxytocin release and more contractions, if suddenly we reduce the labour sensations, we're going to reduce feedback to the brain, reduce central oxytocin release, which is actually important. It's not just reducing peripheral oxytocin, we've also reduced central oxytocin and reduced oxytocin to the uterus. And that's exactly what we find in the studies that have looked at and actually measured oxytocin levels following epidurals. And this is the oxytocin gap. You can see here women without an epidural and the increase. This study measured in the first 60 minutes, the study measured it till birth. And you can see that decrease over the first hour and no increase up till birth. And this bottom one is actually spinal because spinals are so much more effective in relation to analgesia. They have much more of an effect on this gap here too. We didn't have the birth figures for that. But people have said to me, well, what about the modern epidurals? We're using low-dose epidurals that are less consequential. Could that benefit the woman's hormones? And the answer to that question is, from my perspective, from the theory of it, is this feedback loop. So if we do anything that reduces labour sensations, then we're going to reduce the woman's oxytocin responsiveness. So I would say, although we don't have so studies that differentiate by the dose of oxytocin or the dose, sorry, by the epidural drug strength or concentration, I would say that from hormonal physiology principles that anything that numbs a woman's uterus is going to reduce her oxytocin centrally and peripherally. So beta endorphins, we release them under stress and duress. We get the epidural, oh, no pain here, totally abolishes the pain sensation. We get a dramatic drop in beta endorphins. And again, that's what we measure in the bloodstream. There's a beta endorphins gap here. But where they're working is in the brain. So we're going to get a gap within the brain as well. Those reward and pleasure centers are likely to be much less activated. This is a quote from The Girlfriend's Guide to Pregnancy, which really illustrates this, and it's about women getting an epidural. She says, this is generally when pregnant women get their personalities back. They become nice and loving to their husbands and chatty with their girlfriends, which really illustrates that women have exited from this altered state of consciousness with an epidural, which is can be kind of convenient in maternity care, right? The woman's not the kind of elemental force of nature that women with this full hormonal physiology can be, and maybe it's easier to care for women, but there's something really missing from a hormonal physiology perspective. In relation to catecholamines, there's a hormonal gap as well. They reduce adrenaline more than noradrenaline, and that can cause an initial hyperstimulation, which reduces blood supply to the baby. In relation to postpartum, this is what it looks like. So you can see the epidural analgesia ones are the epinephrine, the epinephrine is in the dotted. So this is epinephrine. So just put the thing on. Epinephrine without without epidural, and this is the epinephrine with epidural. So you can see this big hormonal gap from there to there in terms of the epinephrine, the adrenaline levels. A smaller hormonal gap in terms of more adrenaline, but still a significant gap. In relation to prolactin, that hasn't been so well studied. It may reduce the prolactin decline in labour and interfere with the prolactin system after labour and birth. You can see that with an epidural, there's actually less of a prolactin decline in labour, but a big gap after in 4 hours postpartum. And if you recall what I said about prolactin after the birth, it may be there to stimulate the formation of prolactin receptors. So this gap at 4 hours could be consequential for future breastfeeding as well. And that's the $6 million question. So epidurals do have effects on labour. They prolong labour from the drop in oxytocin, especially the pushing stage where those positive feedback loops are not active. It increases the use of synthetic oxytocin to compensate for the oxytocin that we've just reduced. Increases instrumental birth, and the impact on caesareans is a $6 million question. I'm not going to answer that here, but you can look in the report for my comments on that. These drugs, as I said, also cross the placenta, enter the baby. They have a longer half-life in the baby. So bupivacaine has a half-life. The common local anesthetic used is 8 hours in the adult versus 8 hours in the newborn versus 2.5 hours in an adult. So much longer half-life. These drugs stay in the baby's body for much longer. And studies have shown babies exposed to epidurals to be less alert and less oriented, to have control of state problems, to be less able to get themselves out of a crying state for up to 6 weeks. So some interference in the babies. You could set up of physiologic systems from the epidural, which may be the baby, maybe from their mother, maybe from the interactions between them. We can't answer that question. In relation to breastfeeding, again, a highly controversial topic. You can read my findings on that in 3.2.5, but this study showed that fewer exposed babies suckled the breast within 4 hours, are more often given formula in hospital stay, and fewer were fully breastfed at discharge. So I think there is a hormonal gap there. And this is the study that measured women's hormonal release during breastfeeding on day 2, and they found when women had received both synthetic oxytocin and an epidural, they had the lowest oxytocin level, so a double whammy from both of those things. The sense that I make of breastfeeding, just for a quick summary in the report, is that there is a hormonal gap there, and that if we want to bridge that hormonal gap, we need to provide as much support as possible. I'll talk about that a bit more in a minute, but in those studies where the support was provided, the impacts on breastfeeding were much reduced. Some in relation to attachment, we've interfered with all these hormones of attachment: oxytocin, endorphins, catecholamines, prolactin. And there are some studies that measured attachment-type behaviours after an epidural. One found that women spent less time with their babies in hospital, which was in proportion to the amount of bupivacaine they received. And that makes exact sense if you think about the positive feedback loop. The more bupivacaine, the more numbing, the less central oxytocin they're releasing. Another study found babies to be less adaptable, more intense, and more bothersome. Mothers described their babies as less adaptable, less intense, and more bothersome at 1 month, which again is implying some deficit in the mother's reward and pleasure centres. So how do we bridge those hormonal gaps that are there with epidurals? Early and frequent skin-to-skin turning on oxytocin and beta endorphins, early and frequent breastfeeding turning on oxytocin, beta-endorphins, and prolactin. And if we know that there's a gap there in relation to breastfeeding, we'd also provide liberal and easy lactation consultant support as well. So that's epidurals in a nutshell. As I said, there's a lot more detail in 3.2.5, 4.2.5, 5.2.5, 6.2.5. But particularly I'd recommend you read 3.2.5, which is the impact of epidurals on the oxytocin system. So let's look at the impact of caesareans, and some of this you can probably guess already. The mother has lower or absent or hormonal peaks, depending whether she's having a pre-labour or an in-labour caesarean. The baby misses out on the hormonal protection and maybe the preparation as well if it's a pre-labour caesarean. Oh yeah, just mentioning, there's Table 2 in the Hormonal Physiology of Childbearing report that goes into detail about the different kinds of caesarean, because from a hormonal physiology perspective, there's actually a difference between an in-labour caesarean that follows physiologic onset of labour, so mother and baby have all those preparations, versus an in-labour caesarean that follows an induction. Yeah, so you can think your way through that, and it's all in the table. So when we measure newborn hormones just in the cord blood of pre-labour caesarean babies, we find lower oxytocin, slightly lower beta-endorphins, but big drop in adrenaline because the baby hasn't had the catecholamine surge, drop in noradrenaline, and a little bit less prolactin as well. So an impact on the baby as well. So all these catecholamine surge effects that benefits the baby are not present or present to a much reduced stage for the caesarean baby. So these, as I said, it really explains the morbidity, the breathing morbidity. Caesarean babies tend to have low blood sugar, and they tend to get cold as well. Initiates thermoregulation is at the bottom there. So it's really good to remember the catecholamine surge when you're thinking about the impacts of caesareans on babies. We know from lots of studies that it does have consequences for the baby, that there's more likely for the baby to have breathing difficulties even at term, at 40 weeks, twice the increase of breathing difficulties, and even more with earlier gestation. Increased risk of admission to advanced care it was a very large VBAC study, intended vaginal deliveries versus pre-labour caesarean. One study, a very large South American study, a World Health Organization study, found increased neonatal mortality for pre-labour caesarean babies as well. And this study actually differentiated between intrapartum and pre-labour caesarean babies, and it's really what we would predict from hormonal physiology, that outcomes were worse for pre-labour caesarean babies. For example, NICU for more than 7 days, 2.2 times compared to 1.9 times the risk of vaginally born babies. And again, mortality up to hospital discharge was also higher for pre-labour caesarean babies. Does performing caesarean section after the onset of labour have positive effects on neonatal respiratory disorders? Well, you can guess the answer to that from a hormonal physiology perspective would be yes, but this paper was actually published after the report, and they agreed that it can provide a positive contribution. So going back to Table 2 in the report, which looks at the different kinds of caesarean, the optimal caesarean from a hormonal physiology perspective is a non-emergency in-labour caesarean. So the labour has been initiated, the baby's ready, the mother's ready, and then we do the caesarean. Obviously, a much trickier thing to organise within the hospital system, but it could be that we would end up saving, money and saving morbidity for breathing morbidity in particular. In relation to breastfeeding, again, it's shocking that there's few good studies. There's not many. It's not well studied, even in the VBAC studies. Even in some of the high-quality studies don't measure breastfeeding as an outcome. Observational studies do show lower breastfeeding rates after caesarean. There's drugs and drowsiness for the mother and baby. There's often a delay in maternal-infant reunion, so they miss that first hour after birth. They tend to have delayed breast milk production and reduced breast milk transfer. Of course, there's this lack of pre-labour physiologic preparations, and that study that I just mentioned about showing that analysed the mother's release of hormones during breastfeeding on day 2. The pre-labour caesarean mothers had fewer oxytocin pulses and no prolactin during breastfeeding on day 2. So again, we've interfered. There's a hormonal gap there in relation to the mother's breastfeeding hormones. And as you know, interference with breastfeeding is a major and lifelong detriment to the health and well-being of mother and baby. Other long-term impacts, differences in hormonal physiology, gut flora colonization, the microbiome is the topic of the much current research. Differences in DNA methylation, we have measured epigenetic effects, differences between pre-labour caesarean babies and vaginally born babies. So we know that that does happen. Some of future risks for caesarean offspring listed here may be due to, well, we don't really know about hormonal physiology, microbiome, epigenetics as well. For the mother, one study, Australian study, showed depressed mood for up to 8 months after birth. And this was actually in proportion to the duration of the time that it took for her to get her baby back. So for caesarean mothers, the reunion with the baby is equally important as it is for mothers giving birth vaginally, and that's recognised, of course, in the Baby-Friendly Hospital Initiative. So some psycho-emotional effects as well, depressed self-esteem. Some studies have shown increased postnatal depression. Some studies have shown increased post-traumatic stress disorder. Certainly, reduced breastfeeding success is clear, and what effects on attachment, we haven't really begun to look at that. I mentioned the study that showed less activation of maternal brain arousal and reward centres in response to their own baby's cry at 2 to 4 weeks postpartum. So there is a hormonal gap there in relation to pleasure and reward. So again, how can we bridge these gaps? Early and frequent skin-to-skin oxytocin, beta-endorphins, early and frequent breastfeeding can bridge these hormonal gaps. What are the possible long-term impacts of these birth interventions? So all of these studies I've been talking about have only measured short-term impacts. And that's very concerning. You know, high-quality, long-term human research in relation to fetal and newborn exposure to perinatal drugs and interventions is very limited. And the implications of that is that evidence-based publications and approaches which draw on this limited evidence may not provide adequate safeguards for mothers and babies. So when we look at, short-term outcomes for example, breech babies, for example, of, caesarean versus vaginal birth, we're not taking into account the longer-term outcomes. And when we do, for example, the breech birth 2-year follow-up, we find different results. So this study looked at high-quality long-term child follow-up after large obstetric randomized controlled trials for the evaluation of perinatal interventions. So I looked at the kind of studies that are in the Cochrane review and looked at how long the follow-up was. And they found that only 40 of these 249 studies followed the children after discharge from hospital, and only 5 studies followed the children after age 5 and over. So basically, we don't have evidence about long-term impacts. There's a lot of mechanisms, as I'm sure your brain is thinking about at the moment, via effects on breastfeeding and attachment, developmental origins of health and disease. I'm sure many of you are familiar with that. Epigenetics, hormonal imprinting, life course health development, which basically says the life course health development model, which we talk about in the report, is also really helpful because that talks about trajectories. And it says, the early life trajectories are really critical. If it's a few degrees different in early life, it's going to land in a completely different place. And we think that that is probably the case in relation to hormonal physiology of childbearing. So we urge the precautionary principle. So according to the 1998 Wingspread Statement, when an activity raises threats of harm to human health or the environment, precautionary measures should be taken even if some cause and effect relationships are not fully established scientifically. And this is what we believe the state of play is with hormonal physiology. So there are indications that there's threats of harm to human health, and we should really be taking precautionary measures. So in maternity care, this would be operationalized by setting a high standard for deviating from care that promotes, supports, and protects the healthy physiologic processes of childbearing for mother and baby. So as I said, we're not saying that we shouldn't be doing interventions, but we're saying that the hormonal physiology gaps should be taken into account in the benefit-risk analysis, and we should be supporting care that promotes, protects, and supports healthy physiologic processes. So how can we optimize hormonal physiology? Considering our evolutionary heritage, and as I hope that you're aware now, breastfeeding and attachment are critical outcomes that are hardwired into our hormonal physiology and designed to work. So really supporting hormonal physiology is going to support breastfeeding and attachment. And as I said, we don't have a lot of research on implications for maternal mental health, but everything that I've said so far really supports the idea that optimizing physiologic childbearing is likely to optimize maternal mental health outcomes as well. And I hope that someone will do some research on that. If anything in the report, tweaks your interest and you're a researcher, please get in touch with me. I'd love to talk to you about filling in some of these critical hormonal gaps. So optimizing physiologies to support this, and I hope that you've got that message that one of the most basic ways of optimizing physiology in any situation is skin-to-skin and early breastfeeding, or access to skin-to-skin so the baby can initiate themselves early breastfeeding. Limiting the use of interventions that interfere with hormonal physiology and or where long-term impact is unknown, which is basically everything. So we want to limit the use of interventions for situations where it's really necessary. Offer low-tech models of care to low-risk mothers and babies. I know that you're very good at this in Canada, of offering midwifery care as an option within the public health system. Doula care, there's certainly some really good studies. Again, section 5.2.1, where I talk about the impact of birth environment and the epinephrine, norepinephrine systems. We talk about midwifery care and doula care there. Also in the introduction, and there's high-level evidence that those things do reduce the requirement for interventions, and so therefore reduce the chance of having a hormonal gap. Creating a warm, safe, undisturbed atmosphere during labour and birth. I haven't talked a lot about it, but I did mention that from a hormonal physiology perspective, the core requirements for birth in all mammals is that the labouring female feels private, safe and unobserved. So creating a space that feels warm, safe and undisturbed. And I'm not saying that this can't happen in a hospital. I'm not saying you can't do the monitoring that, and observations that are required, but these things can be done with a minimal disturbance of the mother when we realise that those things are important. So minimising the use of drugs and interventions to times that are absolutely necessary, and being aware that these things may produce a hormonal gap. So awareness and support for mothers babies who get a suboptimal start with hormonal physiology. So as we mentioned, exposure to synthetic oxytocin, epidurals and cesareans, but I'll refer you back to the report to look at the impact of prostaglandins, of opiate drugs, even of ergots. In fact, I just want to mention just briefly that, and I'll refer you back to the report, the prolactins chapter. Prostaglandins and ergots are both drugs that reduce prolactin release. They promote dopamine release, which inhibits prolactin release. So those things, the use of prostaglandins in labour could, and in fact there's one study showing that it does have an impact on breastfeeding success. And why we're using ergot derivatives after birth when they inhibit prolactin release and then expecting women to breastfeed, I'm not sure why that is. But again, if you want to do some high-quality research on that, please talk to me. And early separation, again, I haven't talked about that, but that is one of the major interventions that we talk about in the report. So obviously early separation, the mother doesn't have the contact with her baby for that critical hour when her hormonal sensitivity is maximum. So facilitate early and ongoing skin-to-skin contact as soon as possible after birth to reduce stress and stress hormones, to promote oxytocin, beta endorphins and prolactin, and to optimize the baby's self-attachment. And all of this adds up to baby-friendly. So thank you to everyone on the call who's involved in optimizing and working for the baby-friendly hospital initiative, because that really is, you can see how brilliant you are from my talk. Okay, so there are a whole chapter on recommendations to support, promote, and protect physiologic childbearing, and I'm not going to go through them, but each of these recommendations has a discussion and refers back to the section in the report. So the report is highly cross-referenced, and so yeah, whatever you want to find in the recommendations, you can go back and look at in the report. So I recommend that you read that chapter, which is chapter 7 on the recommendations. Okay, so that's it, and we're at 2 minutes before. I hope that everything technically has gone well and that you can all hear me clearly. And yeah, that's the report there again. That's the link, which is in your comments and questions section. And I hope that I've inspired and informed you to go to the report and really use it in your own practice to satisfy your curiosity, to advocate for low technology approaches, and to get skilled in filling in these gaps when they occur. Okay, thank you.
Thank you very much, Sarah. This was an extremely enlightening and very comprehensive overview of your work. I find it entirely fascinating how the physiological process of labor and birth can be so impactful on our lifelong health. The release of your report has been so very timely here in Ontario, as we are reviewing our labor and birth practices and are advocating for access to care and practices that best support informed decision-making and long-term health for families. So in a moment, we will open up the Q&A session. So please feel free to add your questions. There are a couple of there, but we recognize that this information just takes a bit of time to process and to how to apply it to your practice and in your specific situation. So feel free to add any thoughts you have now or any questions you have now, and we'll address them in just a moment. If you have to leave, we are extending our Q&A session now from 5 to 5:10. We know we only advertise this webinar until 5 p.m. But if you do have to leave, we have, as Catherine mentioned, a discussion room that we will have available and open for registrants to post their questions and comments over the next week, and Dr. Buckley will pop in and respond to your questions and comments in that time. So please feel free to do that if you aren't able to wait or stay during this Q&A session. So before we begin that, I'd really like to recognize and thank our partners, the Public Health Association of Canada, the Provincial Council for Maternal and Child Health, the Association of Ontario Midwives, and the Baby Friendly Initiative Strategy for Ontario for their wonderful support in bringing Dr. Buckley to present here. It's been truly rewarding to see so many organizations come together to work on this upstream health promotion initiative. We also would like to just quickly remind you not to please not forget to take a moment to complete the survey that will be sent out to you after the webinar. We always appreciate your feedback. So okay, we will begin the Q&A portion of this at this time, and we again recognize we are keeping you behind, and if you have to leave, that's fine. Where are we here? Please feel free to regularly to pop back onto the discussion board regularly over the week, and you might find some information there. So starting with the first question we have here is that someone was just checking. We think that synthetic oxytocin does not downregulate oxytocin in labor, but women have less oxytocin after the birth. Does synthetic oxytocin downregulate endogenous endorphin response? And the second part is most women remark on how induced labor with synthetic oxytocin is more painful than labor that starts on its own.
Okay, yeah, thanks for that. So, yeah, as far as we know, synthetic oxytocin doesn't give negative feedback to oxytocin in labour. Remember the positive feedback loop, that anything that kind of promotes contractions is going to give a positive feedback loop and can initiate labour if there's sufficient readiness. And then I also mentioned those two studies, one of which was a breastfeeding study showing that women who'd been exposed to synthetic oxytocin in labour had lower oxytocin release during breastfeeding 2 days after birth. So that looks like a kind of negative feedback. So the answer to your question is basically we don't know. We don't know why that causes that effect, but we can presume there's some disruption of the oxytocin system. And one of the ways that so the second study that I mentioned was a study that looked at women, I think it was 2 months after the birth, and they reported more depression and anxiety in proportion to how much synthetic oxytocin they received in labour, and they also had higher oxytocin levels. So one possible explanation, and these are hypotheses, right? One possible explanation is that the exposure to these high levels of synthetic oxytocin in labour has dysregulated the receptor system. So the receptors are less sensitive. So she needs more oxytocin to produce the beneficial well-being oxytocin afterwards. Why are the levels lower in those 2-3 days after birth, if that's the case? Again, I said we don't know the answer to that question, but we could say that the oxytocin system is probably in flux at that time. There's lots of things happening and changing. It's probably setting itself. In fact, it's probably setting itself over the whole duration of the childbearing episode, which is why external hormonal exposures can be so consequential from a hormonal physiology perspective. So I can't give you a better explanation than that. Basically, we don't really know the answer to that question, but we know there's some disruption. In relation to synthetic oxytocin downregulate endorphins, we don't really know the answer to that question. As I said, there's complex interactions between these hormones. Some of those complex interactions are actually unique to the childbearing episode. So I haven't seen research on that, but maybe it would. I don't know for sure. Most women remark on how induced labour with synthetic oxytocin is more painful than labour that starts on its own. And there's a number of reasons for that, like we've interfered with the pre-labour physiologic preparations, and so the woman's not having that increase in oxytocin receptors in her brain. Likely there's an upregulation or an activation of the endorphin systems within the brain to help with intrapartum pain relief as well. So the women who are being induced are not getting those benefits, the pre-labour physiologic preparations for labour analgesia. And of course, as I said, with induction, usually it causes contractions that are longer, stronger and closer together than the woman would naturally experience at that time of labour. You know, labour slowly builds up, giving the woman's endogenous analgesic systems time to slowly build up. So if we suddenly bring on these strong contractions, then her analgesic systems are not going to be able to keep up. So there's a few kind of hormonal physiology reasons why an induced labour is more painful than a labour that starts on its own.
Great, thank you. We have another question. The single high dose of exogenous oxytocin postpartum that reduces endogenous oxytocin, would this be equal to the amount used for active management at third stage?
Oh, okay. So I think what you're referring there to is the animal studies that showed an impact on the... I'm not quite sure what you're referring to, because what I've said is that oxytocin in labour interferes with oxytocin release during breastfeeding. We don't actually have studies on that single high dose of exogenous oxytocin, which is high dose used for active management. The only studies I've seen on that, there was a large Welsh study, the Cardiff birth study, that looked at the impact of various forms of various interventions on the chance of successfully breastfeeding at 48 hours. And that study did show some impacts from postpartum synthetic oxytocin when it was given IV on breastfeeding. It also showed impacts from the ergots, which is what I was talking about earlier before. So what is the, you know, in relation to synthetic oxytocin, what's the impact of the dose of synthetic oxytocin used for active management? I don't really know the answer to that question. And again, I'd refer you back to the report where there's a discussion about ways that it could impact. For example, if it's given, you know, it's often given before the baby's born, so it's given as the anterior shoulder comes out, as the birth is in progress. It could pass through the bloodstream, could pass through the placenta to the baby. It could have impacts on the baby as well, you know, as some of those animal studies have shown. You know, we don't really know the full implications for the oxytocin system, or, you know, really for long-term health and well-being from that single dose of synthetic oxytocin after birth.
Great. We have another question or comment. For women who have obstetric laceration that would be benefited by suturing, what is the optimal timing? In the first hour? Often I find women do not feel comfortable with maintaining baby skin to skin while being sutured, but conventional wisdom is that women will tolerate suturing and tissues are benefited by first hour of suturing.
Yeah, well, that's a good question, and it would make a great study, wouldn't it? If anyone in the audience want to put their hand up to do that study, because, you know, I can't answer that question from a research perspective. But, you know, it's all about risks and benefits, isn't it? So obviously, in the first hour, you know, going back to that oxytocin graph, in the first hour, the mother's oxytocin sensitivity is very high. So prioritizing the baby's skin-to-skin contact between the baby and the mother, I think that really is a priority for long-term health and well-being. You know, we know it's a priority for baby-friendly. We know it in some studies increases baby survival, increases baby's chance of breastfeeding. So from a hormonal physiology perspective, that would be, you know, the most important thing is that mother and baby are skin-to-skin. And you know, the reason that it's, you know, that women will tolerate it more is because they have these high levels of endogenous analgesia at the time. So, you know, I think you've got to ask the women that question, really. You know, how is it to be sutured and holding the baby at the same time? Is there a way that you can, you know, support women to do that, or could you leave it till, you know, later in the first hour? You can see, I'm trying to look at that, trying to find that graph. You can see from the graph that the mother's sensitivity decreases even from 45 minutes. So, you know, how can we deal with those competing interests of the mother's well-being and the long-term well-being, and the need to support her, if you like? And yeah, I mean, I can't really give a recommendation there, but to say that from a hormonal physiology perspective, I'm trying to find that graph. From a hormonal physiology perspective, sort of mother's oxytocin response now, and being skin to skin in the first hour was really important.
Right. There's lots of research questions, it seems, still unanswered and lots to do, right?
Yeah. Have we got some researchers on the line?
Seems we do. We have another question that's coming through here now. If women have had induced labor and epidural and now are showing signs of difficulty with letdown of breast milk, low oxytocin potentially, is there any other triggers we can use aside from skin-to-skin and continual nursing, any massage or other contact points on her body that would produce an increased release of oxytocin?
Well, I like the way you're thinking. So we're thinking from hormonal physiology, how can we optimize the mother's oxytocin? I mean, those big peaks are happening obviously from skin to skin and breastfeeding, and that's the things that are going to be the most impactful in terms of the mother's oxytocin system. We also obviously want to optimize the baby's oxytocin system, so the baby's in this ideal state to initiate breastfeeding as well. So we want the baby to be calm and connected, we want the baby to be skin to skin. I know that people have used the breast crawl, that the baby's designed to do after birth. I couldn't talk about everything, but I do mention that in the report. So the baby has these reflexes. The baby is born in this state to initiate breastfeeding with those high levels of catecholamines. The baby is alert. The baby can walk itself up the mother's body, locate the breast, massage the mother's breast, as we see in this thing here, and then latch on themselves, giving an ideal start. And when the mother's had drugs in labour, the baby's likely to be affected by drugs in labour. There's some research on that I quote in the report showing that even separating the baby just for weighing and measuring can impact the baby's breastfeeding success, the ability to do a successful latch. So, uninterrupted time between mother and baby for as long as it takes, and the longer the better. And obviously I'm not saying do it when the mother needs to have a shower or, to the detriment of the mother. You leave it to that. But we want to encourage as much skin to skin and the baby's access to the breast. And when the baby's had, been exposed to these drugs and interventions as well, it's going to take the baby longer. So patience really, I think, is the big thing here. There are, some studies have shown that lots of things increase oxytocin. I said like hugging and music and massage and all those things. But whether those things are actually helpful in this particular circumstance, we're not just talking about the general oxytocin system, we're talking specifically about the oxytocin system in reproduction, which is a little bit different actually. It's a pulsatile release in labour and birth. It's a pulsatile release in breastfeeding, and oxytocin outside of reproduction is kind of a constant release. That's the feel-good kind of hormone. So yeah, it's a little different. So I can't really recommend any of those, any of those things specifically. There's again, anyone want to do some research on this? But anything that helps the mother to feel relaxed, helps her to get into that calm and connection state with her baby is going to be helpful to her, and it's going to be helpful to her baby. And it's really interesting because I went to a breakout session in a conference a few years ago where Kirsten Ivnas-Moberg, the oxytocin guru, was there talking about the impact of synthetic oxytocin on breastfeeding and the long-term impact as well, and those figures from that follow-up study on child development that showed an impact on child development from exposure to synthetic oxytocin, where all of those things were presented. Michelle O'Donnell was there, she was there, Leslie Page was there, a few other people, and her, Michelle O'Donnell was saying, well, yes, of course, the synthetic oxytocin's got through the placenta and has affected the baby directly, causing these impacts on development. But Kirsten Ivnas-Moberg actually said, I don't think it's that. I think it's actually affected the mother's hormonal state, and her hormonal state has affected her baby's development. So, what she's saying is that we know that these things can impact the mother's hormonal output, and so probably the mother's hormonal state, in the brain as well. So one of the best things we could do here is to promote an environment that's going to optimize the mother's oxytocin system. And look, massage sounds good. If you massage me, I'd feel more relaxed and calm and connected as well. But as I said, the idea really would be to have some research into how can we optimize hormonal physiology for women in these kind of situations.
There's lots of ways that we can feel calm and relaxed, but it really is very specific to labor and birth, this hormonal physiology. And I think we need to really look at all of the different things we can do to optimize that environment for supporting our mothers and babies to have the best hormonal physiology of birth, to have the best opportunity to have health in the future going forward. So I'm looking at our time, and I'm going to have to wrap it up. I'm sure people would have you on the line all night, and so we're very grateful to have, or all day for you, I guess. We're very happy that you have offered to have this discussion room option, and that people still have the opportunity. So any questions going forward, please post them on the discussion board. And maybe, Daniel, if you could put that up so that people can see what that looks like. There it is. And so you just log in the same way that you logged into the webinar, and it will be open for a week, I guess, until next Monday evening, I'm assuming, Sarah. Is that fair for people?
Yeah, that's fair enough. Just remember that I'm on the opposite time zone, so you're probably going to have to wait 12 hours for me to respond. And also, I'm happy to respond to other questions. If you go to the report and read the report and have a question that arises out of that, I'm happy to answer that as well.
That's very generous. Thank you so much for your time and your wonderful presentation. And I think we've got a lot to think about, and I think there's a lot of ways that we can incorporate this work into different aspects around breastfeeding, attachment, labor, different aspects around breastfeeding, attachment, labor and birth, informed decision making. There are lots of different areas. So thank you for your time. And we appreciate everybody's patience and listening a little bit longer here. And we will wrap this webinar up at this point. And thanks again to everybody involved. Have a great day.
Yeah.